back, everyone. I hope you had a chance to get up and stretch your legs and maybe grab some water, settle back in for our next session. We are excited to have our next speaker with us, Dr. Shane Shapera. He obtained his Doctor of Medicine in 2003 from the University of Toronto and went on to continue in Toronto during his internal medicine and respirology residency training. With the help of the Dr. Cameron Gray Award, he completed an additional year of clinical fellowship with an emphasis in interstitial lung disease. He was appointed to the Faculty of Medicine as clinician educator in December 2011. He's been an innovator in his role as an educator and has received numerous teaching awards since his appointment. He is currently the director of the Interstitial Lung Diseases Program at the Toronto General Hospital, which is a part of the University Health Network. He also works with the Toronto Lung Transplant Program, providing pre-lung transplant assessments for patients with the ILD. Dr. Shapera, welcome. We're thrilled to have you. Thank you so much for your time. I see you've got your slides ready to go, so we'll pass it over to you. And again, welcome. Thank you for being with us. I see you're muted.
There we go. Are you guys able to hear me now?
I can hear you. Thank you.
Excellent. Great. The usual Zoom type technical glitches as we get started, so no problem. Well, thank you so much for that lovely introduction, and thank you for inviting me to speak today. I'm really thrilled to be talking about scleroderma-related lung disease. Before I get started, just a few of my disclosures here that I've worked doing research. I've worked in an advisory capacity for a few companies that make drugs that I'm going to talk about today, and I've done some speaking engagements. I think probably the biggest disclosure to make is just to let you know that there are very few approved therapies to treat scleroderma lung disease and other connective tissue disease, ILDs. And so many of the treatments I'm going to talk today are what we call off-label indications. And just to let you know, I will let you know about the one on-label indication for a drug that I'm going to talk about, but everything else is what we call off-label. So my goal is at the end of today's talk, you will be able to describe what we mean by scleroderma lung disease, understand the risk factors for scleroderma lung disease, and discuss the evidence for and against anti-inflammatory and antifibrotic treatment of scleroderma lung disease. So what do we mean when we talk about ILD or interstitial lung disease? So ILD is a chronic progressive scarring of this area of the lung that I describe as the scaffolding of the lung. For example, if we were to think about the lungs as a building, you know, the hallways would be the airways, the plumbing would be the blood vessels, and then the scaffolding or the interstitium would be things like the walls and the girders and the studs that are hiding in the walls. And so in ILD, we get this progressive scarring of that scaffolding. The cause of that scarring can be known, things like scleroderma or asbestosis or farmer's lung, or the cause may be unknown, and that's when patients get a condition called idiopathic pulmonary fibrosis. Why do we care? Well, as the lungs get thicker and scarred, they become stiff. And as we try and breathe with our stiff lungs, it's more work to open up a stiff lung than a soft, normal lung. And that makes people feel breathless. As the lungs become more scarred, they also are not as good at exchanging oxygen and carbon dioxide. And so you can end up with low oxygen levels. And unfortunately, because these conditions are progressive, lung function can get worse over time. How do we assess our patients? Well, if you're watching this diagram, I'm just going to show you this lung on the top here is breathing in and out. And you can see that red line going up and down as it breathes in and out. Now I want you to imagine what would happen if that lung started to take deeper and deeper breaths. You can just imagine the lung would take increasing breaths and in and out, in and out. Eventually, that lung would go from all the way full to as empty as it can go. that area, that amount of air that you blow out from as full as you can get to as empty as you can go, we call that the vital capacity. Now I'm going to tell you just a little bit more about the vital capacity. As your lungs get stiff and they get more thickened and scarred, they will start to shrink. And as a result, the vital capacity gets smaller. So you can imagine that as everything kind of gets scarred down, it all gets a bit smaller. We measure this vital capacity by asking our patients to force the air out of the lungs. And many of you on the call today will remember when someone put this thing in your mouth and said, blow out as hard as you can. This forced vital capacity is the measure that we use to determine how big your lungs are. And that is the most important number that we have when we're measuring people's lung capacity. And more importantly, a change in that vital capacity means that your lung disease is getting worse. So we monitor for a change. Oh, part of my screen is blocked. All right, I think I'm going to stop sharing and reshare because I see that there's something on my panel. So let me stop and reshare. Thank you for that person who was making the comment. It's a bit glitchy, but let's see if that works. I'm going to ask if people are saying that that's looking better, and I'm going to continue, but just feel free to make comments if there's any problems with the with my view. So now that we've decided a little bit about what it is that we're measuring when we measure the vital capacity, the next question is, who gets this lung problem? So scleroderma ILD occurs in up to half of the patients with scleroderma. The clinical course of scleroderma lung disease is variable. October 2020 is still in the middle of the screen. That's a very odd problem. Let me try one more time. Sorry, everybody, for the technical problems. My Zoom is super sketchy. It's kind of going in and out, and I'm not getting, it's flashing all over my screen. Let me try over here. As I said, you know, you sort of always expect some technical problems. All right. My screen is very glitchy, so I'm just going to have to close out and I'm going to log back in. I'll be right back in one moment. Sorry, everybody.
Thanks, everyone. Sorry about that. I do see your messages coming in. Kara, Lori, Jillian, I see a few of you who have reached out to let us know that October 2020 was showing in the center of Dr. Shapera's screen. So I apologize. As he mentioned, he's just logging back out. I'm sure he'll be right back in to join us. I believe he's coming in now. Bear with me just a moment. I do see Dr. Shapera joining us, so hopefully he'll have an opportunity to get his slides reloaded. Welcome back. Let me make sure that we can connect your mic. Just a second, Dr. Shapera, sorry. Oh, sorry. Go ahead. Try that now.
Are you guys able to hear me now?
No, I can hear you now. Yes, thank you.
Great, but I am still having some odd glitching. Everything is sort of jumping around, so I apologize if people are having trouble, but please, on the Q&A, you can try and reach out to me, and we'll see if I can get better stuff. I am still having a lot of jumping. You're able to see everything now, though?
Yes, but your background is brown, which is the same color as what that October 2020 is. So I still see, can you flip to your next slide? Would you, oh, no, that's better, but there's something on the left of your screen.
Yeah, my screen is very glitchy. I'm not sure why that's happening, guys. I've done many of these Zoom talks and it hasn't done this before. Try one more time. Connect. Are you still getting some weird pictures on there?
I can see your answer to, or I see you've got the question and answer.
Oh, did I pick the wrong,
yeah,
wrong thing to share? Golly gee, it's quite a Zoom kerfuffle here. Sorry,
We'll
everybody. Yeah, we will definitely get there. And again, I really apologize. I'm.
Oh, it's okay.
Share.
I'm happy to present your slides for you. It's just that.
Yeah, I can send them if you like, but I'm. I find that often is a bit of a struggle because I'm. I use a lot of animations, so it can be challenging to see where we're at. How does that look now?
Better. There is still a, yeah, but this is better. So if this.
There's this blue bit on the top. Are you seeing that as well?
Is not really getting in the way of anything. So why don't we see how that.
So we'll keep trying there and see. So as I was saying, about half the patients with scleroderma will develop ILD. And the clinical course can be quite variable. Many patients will have mild and stable disease with few symptoms, and some can have severe and progressive disease. How we predict who will get mild disease and who will get severe disease is a real challenge. But there are some risk factors that we've identified that can show us the risk factors for progressive disease. There are 5 commonly thought of risk factors. The first is if you're fresh in your disease. So if you recently got diagnosed with scleroderma, you're much more likely to progress than if you've had scleroderma for 10 or 15 years. There are certain antibodies that predict having progressive lung disease, specifically this topoisomerase antibody, or another name for that is an SCL70 antibody. If you've got a lot of lung involved when you first come to my clinic, if more than 20% of your lung is involved on your CAT scan, that also predicts a poor outcome. And if your lung function is worse at baseline, so if this FVC, this forced vital capacity, is less than 70% at baseline, that is a higher risk factor for getting worse. Finally, and really a lot of these other ones are sort of tied into this, if your lung function is getting worse over time, that would mean that you're more likely to get worse in the next 6 to 12 months. And that kind of fits with the other few that I've mentioned here, that if you have a lot of abnormal lung and your lung function was low, no one is born with a lot of abnormal lung or low lung function. So if we're seeing people who have those things, probably they have progressed. And similarly, if we're seeing them progress under our watch, that means they're more likely to progress in the future. So these are sort of the standard risk factors for our scleroderma lung disease. So I'm going to use this case, and thankfully, although I know the top of my screen is a little blurred out, the rest of the screen is what you're going to need to see. This is a 58-year-old woman, and to be honest, I've changed her name and her initials and her location. But to give you an idea of one of these patients who comes to me from pretty far, this patient that I'm describing comes to see me in Toronto from Thunder Bay, so she has to fly down for each of her visits. And she was initially referred to me in 2008 to assess her lungs. At that point, she was fit and active and really had no symptoms. But she came back 3 years later with breathlessness that had lasted about 6 months, a dry hacking cough, and she was slowly getting worse. And she had tried using antibiotics and puffers, and it hadn't helped. And this is what her lung function looked like over time. So on the left, you see her FVC in December 2008. You can see that by December 2010, it was worse. And I brought her back to see me about 6 months later, and it had dropped even further in that next 6 months. So this was a danger sign. I can tell that this person's lung disease is getting worse, and that predicts that they're going to have a worse outcome. Now, as far as how we treat scleroderma lung disease, well, a lot of this is just getting back to basics. You know, I think of these as motherhood statements, things that everybody should do, but they apply even more to people with scleroderma. For example, we should look for and treat other causes of cough and breathlessness. So in scleroderma, we have to think about pulmonary hypertension, which is another problem that we're not going to talk about today. We have to think about acid reflux, because lots of our scleroderma patients have problems with their swallowing that can cause acid reflux. We have to remember that deconditioning is often a problem for our patients, and so I strongly recommend that my patients try and stay as active as possible. And if there is access to a rehab program, that would be great. And vaccination should be strongly encouraged. So I think all of my scleroderma patients should have an annual influenza vaccine. They should get the pneumonia shots about every 5 or 10 years. And once a COVID-19 vaccine becomes available, they should take it. But then the question is, when do I start consider actually treating my patients with scleroderma lung drugs? And this is a difficult question because in a lot of my patients, their disease may not be active. You know, they may have early disease that's found incidentally or subclinical disease. We sort of think of these patients, some of them will get worse, but others might have little bits of scarring in the lungs that will last for many years. Similarly, late disease, when you've had it for a long time, it could be kind of burned out. Scleroderma lung disease can act kind of like a fire. It can burn hot in the first few years, and then it can kind of burn out and not progress very much. So the challenge is knowing when patients fall into this category and when they have real progressive disease. And so the balance of risks and benefits have to be weighed because the treatments are largely based on relatively poor quality data. And once treatment is started, it's typically maintained for many years. Now, how many years, we don't know, but it is quite a long time. For sure, we would treat people for at least a couple of years, but almost always we would treat for even longer. So because of this balance, in my mind, I think that we should start people with scleroderma on treatment if they have both abnormal lung function and we're seeing progression or worsening lung function over time. That, to me, is a really worrisome sign. That means we need to get in there and try and stabilize things. Is that the right thing to do? I don't think any of us really know, but this is what me and many of my expert colleagues around the world are doing right now. Now, what treatments are available? And I'm going to talk about 4 different types of treatments today. 3 of the treatments are in the category that we would call immunosuppressive therapy. This is medications that push down your immune system so that it cannot attack itself. And then one other treatment is in a category called antifibrotic therapy. And we'll talk a little bit about what that means near the end of the talk. So first, let's talk about that first drug that I mentioned there. The first, I guess I should list them off. Sorry, I realized I didn't list them off for you. The immunosuppressive therapies we're going to use or talk about are cyclophosphamide, myophenolate, and rituximab. And the antifibrotic therapy that we're going to talk about is called Nintentive. So let's break down each of these and look at the data for them. So cyclophosphamide was looked at in a study called the Scleroderma Lung Study 1. What this study did is it took patients with scleroderma and lung disease, and it randomized them to give half of them cyclophosphamide and half of them a placebo for 1 year. And here's what they showed. And you're going to see all my graphs are going to be about the same in their orientation. They're all going to have time on the horizontal axis and lung function in the vertical axis. And remember, if this FVC is how much air you have in the lungs, you want that number to be as big as possible. So the higher that number, the better. And what we saw in this Scleroderma Lung Study 1 was at the end of 1 year of treatment, you had modest improvements in lung function. So you can see this open circle, the number of FVC is a little bit higher than it is in the placebo arm, which is the dark circle. What was really interesting is that even after you stopped the treatment, over the next 6 months, the lung function actually got even better. So the effects of cyclophosphamide seemed to last even after the drug was stopped. And there, at 18 months, lung function kind of peaked where they were quite a bit better than the placebo arm. But once you were off the drug for 2 years, all of those benefits were lost. So although you peaked at 18 months, if you didn't continue to treat their patients over the subsequent 6 months, their lung function just went down to the point that they looked almost the same as the people that had never gotten any treatment. There were lots of problems with cyclophosphamide in this study, lots of side effects. In particular, it can cause low blood counts, bladder problems, and we think that cyclophosphamide slightly increases your risk of getting certain kinds of cancers. So what's the take-home message from this study? Well, the Scleroderma Lung Study 1 showed us that cyclophosphamide was the first drug to show that we can improve lung function in scleroderma lung disease. But the benefits fade over time if the treatment is stopped. That's part of why we talked about being on treatments for a longer time. Side effects were common and can be serious. So, this is sort of how you feel when you hear those results. And what we're really looking for is, are there other treatments that have less side effects that could still work? And that's what takes us to our second major study that I want to talk about. And this is called the Scleroderma Lung Study 2. What this study did is it took 142 patients, and it gave half of them that cyclophosphamide for a year that we talked about. And then it gave the other half this other immune suppressing drug called myophenolate. And they continued the myophenolate for 2 whole years. And what they showed was that both groups seemed to get better over time. So here on this graph, you can see time again on the horizontal axis, lung function going upwards, up is better. And you can see over time, both the red line, the cyclophosphamide arm, and the blue line, the myophenolate arm, both got better by about the same amount. This is really reassuring and really good news. Not surprisingly, we saw more side effects with cyclophosphamide because it's a medicine that has a lot more side effects. So it's really nice to see that we have a drug like myophenolate that seems to be equally effective, but without as many side effects. One of the maybe even more important findings of this study for me is this graph that looked at quality of life. And in the Scleroderma Lung Study 2, we saw that both patients on myophenolate and cyclophosphamide both had an improvement in their quality of life over time. And for patients, this may be even more important than having your FVC, something that you can't even know about, get better. But it shows us that we're not just improving lung function measures, we're also improving the quality of life in our patients. So the take-home message from the Scleroderma Lung Study 2 is that both cyclophosphamide and myophenolate seem to improve lung function, or FVC. But it is clear that cyclophosphamide has more side effects than myophenolate. So, we all kind of want to celebrate. And as we're getting up towards the next American election, some of you may remember that this was from one of the debates in the last election. And we kind of all remember how that ended, right? And so before we celebrate too much, it's important that we think about some of the unanswered questions. Because this study that I showed you, the Scleroderma Lung Study 2, was essentially it was a negative trial. The goal of the study was not to show that myophenolate and cyclophosphamide were the same. The goal of the study was to actually show that myophenolate was better than cyclophosphamide. Now, we didn't show that, but we showed that both of them seem to work. So I think many of us can make conclusions from this study that it works, but we have to take that with a grain of salt because they didn't show exactly what they had hoped to show in that study. The next question is, are there some patients that benefit more than others? And we don't know which patients are the most likely to benefit from these treatments. When is the right time to start the drugs? We talked before about people who can be subclinical or too early, and we talked about people where they can have burned out disease. Do they benefit the same way as the people who have active lung disease? We don't know. And maybe even a more relevant question is there a role for one and the other? We wouldn't use these drugs together at the same time, but could there be a role for cyclophosphamide first and then myophenolate second? Or would we use cyclophosphamide as salvage therapy? If you had a patient who was on myophenolate and getting worse, since the cyclophosphamide seems to be a little bit stronger because of its side effects, maybe that would be like your second-line treatment. We don't know the answers to these questions. But I will tell you what I did in this patient's case. So with my patient, we had a detailed discussion together because we were seeing that her lung function was clearly getting worse over time. So she decided to take 6 months of cyclophosphamide. It was not as long as the 1 year that was done in the studies, but we decided to do it for 6 months. But even back in 2012, long before any of these studies had come out, I was somewhat convinced that myophenolate was probably effective, and many of us thought this just from our experience. So I did exactly as I described. I gave her 6 months of cyclophosphamide, and then I gave her 2 years of myophenolate. And I want you to notice that at the end of that 2.5 years of treatment, I got her vital capacity right back up to where it had been when we first met back in 2008. That's really exciting, and I think that's where we're at today in scleroderma lung disease. The next thing I want to talk about is rituximab. So that's the third immunosuppressive medicine I want to mention. Rituximab is another kind of immunosuppressant that works in a different way. This has not been studied as well, but there was this study called an open label study where what they did is this group took 51 patients who they followed in their clinic who were being treated with various treatments, cyclophosphamide, myophenolate, and even some other things that haven't been as well studied or well proven. And they offered to them that they could stop what they were taking and try this other drug called rituximab. They thought it might work, and so they said to the patients, if you want to, you can try it. And if you don't want to, you can be in the study and stay on your current treatment. Of those 51 patients, 33 of them decided to be treated with rituximab, and 18 of them said, sure, I'll go in your study, but I want to stay on my current treatment. And what they showed was that rituximab was associated with a significant improvement in lung function over the next 7 years. What we're seeing here is you can see in the red arm, the rituximab group, you can see their lung function is slowly going up over time. Whereas in the standard care group, their lung function is slowly going down over time. Now, this rituximab is very expensive and it's very hard to get access to the drug. And this study that I'm showing you right here is not as good quality as the scleroderma lung study 1 and 2. This was an open label study. Patients weren't randomized to go into one group or the other. They got to choose which group they went into. So from a scientific evidence perspective, this is a little bit lower quality evidence than the other two studies that I mentioned. But it's very exciting, and it does suggest that there may really be a role for rituximab in scleroderma lung disease. So that's sort of where we're at right now. The next thing I'd like to do is talk about where we're going in the future. And the future involves this drug called Nintentive in scleroderma lung disease. Nintentive is a completely different class of medicine than the other three that I've mentioned. This is not an immunosuppressive medicine. Nintentive is in a class of drugs called antifibrotics. And the idea of this drug is that it stops the body from laying down scar tissue or fibrosis. It was initially developed to treat a disease called IPF, or idiopathic pulmonary fibrosis. And it was approved to treat IPF in 2015. But until recently, IPF was the only disease where we ever used this drug. There are lots of potential advantages of Nintentive. The main advantage of this drug is that it does not suppress the immune system. So you're not at increased risk of infections like you are with some of the other drugs. And because it acts in a totally different way, a lot of us believe that you could use it in combination with our standard treatments. But there are also potential disadvantages of Nintentive. The main disadvantage of Nintentive is that it slows down your body's ability to lay down this scar tissue. But it doesn't get rid of the scar tissue you already have. And so the idea is that patients will still get worse on the treatment. The hope is that they'll get worse more slowly, but we do think that the fibrosis will still progress. The other downside of Nintentive is that it doesn't seem to affect the skin, the joints, or the muscles. It only really affects the lungs. And these other parts of the body, the skin, the joints, the muscles, they can be a big deal for our scleroderma patients, and so we don't want to ignore that. Now, Nintentive was looked at in a study called the Census Trial. And what this did was it gave people Nintentive or placebo for 1 year in 576 patients with scleroderma. Now, just want to draw your attention to that number, 576 patients. This study was just published about a year ago. And I want to remind you of what the numbers look like for the other studies that I've talked about. The scleroderma lung study 1 had 158 patients. The scleroderma lung study 2 had 142 patients. And that rituximab study that I mentioned was 51 patients. Like, this study blows the other ones away. This was way bigger. And when studies are much bigger, we can be a lot more confident in the results because we're doing it in more people. And so we get more confidence in our results. And here's what we saw in the Census Trial. What we saw was that the people in the placebo arm had their lung function go down, right? That's the light blue arm at the bottom. You can see the lung function is getting worse over time. But it's very clear that the people on Nintentive Although their lung function goes down, it goes down a lot more slowly than the people who are on placebo. This result was very exciting. And I will tell you that this Census trial has really changed how we think about scleroderma lung disease, because Nintentive got approved by Health Canada to treat scleroderma lung disease on November 22nd, 2019. This became the first drug available in Canada to treat scleroderma lung disease. And many of you may feel like you're so excited you can't wait to go on it. But the real question is, who's going to pay for it? This drug is expensive. It costs about $30,000 per year. As far as access, well, I mean, paying out of pocket, nobody can pay for this drug, except for maybe Donald Trump. There's no one else who I think can come up with $30,000 a year to pay for a drug. For people who have private insurance, most private insurance policies will cover Nintentive. But for people who don't have private insurance, they have to use a government program called the Exceptional Access Program. And those negotiations for who's going to pay for it are still ongoing. And it's likely that for people without private insurance, this drug won't be available until 2022. So it's going to be about another year and a half before we can use this for all of our patients who need it. Now, remember, not everybody needs it, but that group that you do want to treat, the people who have progressive lung function decline over time. So I know it's cut off at the top, but this last slide is really just about, says, just tell me what to do. And you know, a lot of my patients and a lot of the doctors where I give opinions to, they just say, well, tell me what to do. And here is what I generally do with my patients. So if I have a patient with scleroderma lung disease, and I know it's cut off, but that's all right. Once you've been diagnosed with scleroderma lung disease, that's what the box at the top should say. I would monitor those patients every 3 to 6 months. And if I see that they're progressing, that their lungs are getting worse over time, then I would start those patients on myophenolate. Even though Ofev, or Nintentive, is the first drug approved by Health Canada to treat scleroderma lung disease, we've been using myophenolate for a long time. It's not all that expensive, and I do believe that it works. And it has very few side effects. So this is generally my first line of treatment for my patients. Now, there may be some patients where I might consider treating them at the time of diagnosis, particularly if they have those high-risk features that I mentioned at the beginning. I wouldn't necessarily wait for someone with a lot of high-risk features to get worse if I think that it's very likely they will get worse, and I might start them right up front on treatment. If you're on myophenolate and you're getting worse, then it depends on how you're getting worse. If we're seeing predominantly lung involvement, so it's the lungs that's getting worse, with minimal skin, joint, and muscle disease, then I would probably add Nintentive to the regimen. So you'd be on myophenolate and Nintentive. On the other hand, if I think that you have significant extrapulmonary disease, so what I mean by that is disease outside of the lungs, so skin, joint, muscles, those patients, I would probably add one of either rituximab or cyclophosphamide. And to be honest, how I pick between those is a lot having to do with coverage. Cyclophosphamide is very inexpensive, and I think it really works. So I tend to use it for people who don't have insurance or don't have the ability to pay for rituximab, which is expensive. But if I have coverage, I often will use rituximab instead because I think it also works, and its side effects are better than cyclophosphamide. Now, what happens if you're on these drugs and you're getting worse? So now let's imagine if you're on myophenolate and Nintentive and you're getting worse. Well, then I would probably add either rituximab or cyclophosphamide. Conversely, if you're on myophenolate and rituximab and you're getting worse, then I would probably add Nintentive. And eventually, I think a lot of my patients are going to be on 3 different treatments for their lungs: myophenolate, Nintentive, and or rituximab or cyclophosphamide. But it is important to remember that around this time, different drugs, that's when we should probably be considering whether or not this particular patient is a candidate for transplant. Because if you're getting worse on that cocktail, I don't have a lot of the other options. And we're fortunate in Ontario to have a large lung transplant program in the city of Toronto that our patients can have access to. But that's easier said than done, especially for the people who live further away. It's not so easy to pick up, if you live in Thunder Bay, move to Toronto to get a lung transplant. But it can be something that's available for some of our patients if they're getting worse on all of our drugs. So to summarize, scleroderma lung disease occurs in about half the patients with scleroderma. And the risk factors for progression are early in the disease course, and severe or progressive disease over time will predict worsening disease in the next 6 to 12 months. Immunosuppressive therapy may improve lung function, and that particularly means drugs like cyclophosphamide, myophenolate, and rituximab. These are all reasonable options for our patients, and a lot of the decision about which drug you use might depend on your doctor's comfort with these different drugs, your ability to get coverage for these drugs, and it might also depend on the non-lung parts of your disease, because these drugs will also treat skin, joints, muscle, and so the doctor may choose one that's better for your skin when all of them would be acceptable for your lungs. Antifibrotic therapy is a new treatment for scleroderma lung disease, and Nintentive does clearly slow the rate of lung function decline. This is the first drug that's officially approved for the use in scleroderma lung disease, which is really exciting, but the question is who's going to pay for it? I'd like to say a big thank you to everybody who works with me. I don't work alone. I work in a large ILD clinic at the Toronto General Hospital. I'm the program director, but I have 4 other doctors who work with me, a couple of administrative assistants, some research staff, and a nurse practitioner, and I really couldn't do it without them. And so at that point, I'm going to stop and hopefully allow us, even with the technical pieces, hopefully that'll still leave us about 10 minutes for questions. Okay, so I should have stopped sharing my screen, and people can feel free to ask if they have any questions for me. Someone is asking if they can have a copy of our PowerPoint slides. I have to talk with our coordinators to determine that, because a lot of the data that I've presented is actually taken directly from the manuscripts of these studies, and that information, a lot of it is copyrighted. So at the bottom, I wrote the references, but I won't be able to put those actual graphs and figures in because I don't own the copyright to those things. But what I can do is send out a version of the slides that has all of the tables removed, but the references will be on the bottom, and you can look them up yourself if you like. Next question is, do patients with limited systemic sclerosis get ILD, or is it more likely in the diffuse sclerosis patients? That's a great question. So the answer is that the diffuse scleroderma patients are more likely to have this antibody profile that is at higher risk of getting ILD. So at the very beginning, I mentioned that one of the risk factors for progression is having this topoisomerase antibody, or the SCL70 antibody. That is a risk factor for developing ILD. So overall, we think that diffuse systemic sclerosis patients are more likely to get ILD and progressive ILD. But I will say that I see lots of both limited and diffuse scleroderma patients in my clinic. So although one is a bigger risk factor, we can see both. The next question is, how do I see COVID-19 affecting my patients with ILD? It's a great question. And the answer is, it's not good. And I don't want to alarm people and scare people, but the truth is that it's probably not a big surprise to know that ILD, whether it's scleroderma or another kind of ILD, counts as a pre-existing condition that increases your risk of having poor outcomes with COVID-19. There was recently some data published out of Europe that clearly showed that patients with ILD of any kind who get COVID-19 and end up in hospital with their disease, they don't do very well. So that doesn't mean that everybody who has scleroderma ILD and gets COVID-19 will die. I'm certainly not saying that, but I think it is important that we're really cautious and that our patients take extra precautions because they can get serious disease. one question was saying, in the real life example that I used cyclophosphamide and then added mycophenolate, and that doesn't match the plan that I outlined in my presentation. Why did I do that? And the answer is, if you remember, I saw that patient back in 2010. Back then, we didn't know as much about mycophenolate and whether or not it was an effective treatment. So I already had an inkling that it would work. But before we had the real data, I was nervous in this young woman to use that as my first line treatment. Now you're right, I would do things differently. So about 10 years later, I would use mycophenolate before cyclophosphamide. I'm getting a question about whether or not there's an association between ILD and sleep apnea. And the answer is there seems to be a slight association between sleep apnea and ILD, but it hasn't really been teased out very well. And so we don't really know how those two things are associated. The problem is that sleep apnea is very common. It affects up to 25% of men over the age of 50, and a little bit less in women, but still very common. So the question is there really a relationship, or is it just that we're seeing a common disease, sleep apnea, in people who have scleroderma? And I don't know the answer to that question. There's a question of whether or not the age of onset factors in. And the answer is, we don't really know. But I will tell you that in general, my experience is that younger people who get scleroderma tend to have a more aggressive course. So when we're seeing pediatrics patients with scleroderma, they tend to have a more aggressive course than people who are diagnosed in their 50s and 60s. And so, of course, I'm not making any specific medical recommendations, but I know it is a challenge for people in Ontario who have pediatric scleroderma to see a doctor because they don't have a lot of people who are experienced. What I will say is that there is a really good rheumatology group at Sick Children's Hospital in Toronto, and some of their patients graduate as they get older. As they get older, they come to me. So if people are under 18, they can go to Sick Children's Hospital, and if they're over 18, then they should be referred to a local rheumatologist and a local specialist. The next question I'm seeing is, how often should you get pulmonary function tests? And I think this is variable for each person. In general, I do breathing tests every 3 to 6 months on my patients. But if you've had lung disease for a really long time and it's been very stable for many years, it might be quite appropriate to do your breathing test every 8 months or every 12 months. How long do you treat, or how long does MMF work for most patients? We don't know the answer to that question because the studies only looked at a couple of years of treatment. And so my experience is that the drugs will work for quite a long time, and I have patients who've stayed on it for many years, but it does seem like eventually the drug stops working. And I don't know when that happens and how we predict how it happens, but there's no doubt that some people will eventually lose effectiveness of their mycophenolate. Other people, though, will stay stable for many years on that drug, and I have people who've been on it for 10 years or longer and who are doing really well. This next question is asking, after a year of cyclophosphamide, how long do I continue mycophenolate with stable disease? And this is sort of getting at the same question, but in a slightly different way. This question is more asking, if patients have stable disease, I'm going to imagine that a patient's on mycophenolate for a year, 2 years, 3 years, maybe longer. How long do you continue them on the drug? And the answer is we don't know. We'll often reevaluate at each visit, and a lot of it will depend on the patient and how they feel. Some of my patients want to stay on this drug for a really long time because if it ain't broke, they don't want to fix it. Other people are really keen to get off their drugs. And so I think with each visit, I recommend you have a talk with your doctor, discuss the risks and benefits of staying on therapy versus stopping it. And some people will choose to go off treatment, and that's fine. But if you do that, I do recommend that you continue to monitor things closely with your doctor. Don't stop drug and then disappear from your doctor's radar for a couple of years and then come back, because the worry is that in that time window, you may have lost lung function that we may not be able to get back. One patient is asking a little bit about a drug called Carapool as a precaution for better blood flow and asking me my opinion. And so what I'll say about that is, first of all, unfortunately, in this particular venue, I'm not going to make any specific medical recommendations to anyone about their treatments because I'd have to do a formal and thorough assessment of a patient to decide what drugs they should be on and when. But the other thing that I'll say is that Carapool is not used to treat interstitial lung disease or pulmonary fibrosis. This is a treatment for pulmonary hypertension. So I'd encourage anybody who's on a treatment for pulmonary hypertension to discuss the risks and benefits of that drug with their pulmonary hypertension doctor. So a few more questions, and I'm aware of the time, so I'm going to take about 4 more questions, and then we'll wrap up. The next question is, are regular CT scans recommended with ILD? This is a very difficult question to answer. We don't really know how often we should scan our patients. I think all of us agree that we do need to scan our patients regularly, but how regularly is not clear. Most of us in Canada who are experts in the area would say that you should probably have a CAT scan done every 2 to 3 years. The idea is that just keeps track of where things are at. Breathing tests are probably a better way to monitor the disease, but we can still get some information from the scans. And so I think about every 2 to 3 years is reasonable. But I know for a fact that there are some doctors in Canada and even in Ontario that do scans more often, every 6 to 12 months. And there's other good doctors in Canada who might only do a scan every 5 years or so. So there's no absolute consensus. And the message is that with your doctor, you should look at how you're doing. If you're getting worse, there may be a role for doing a CAT scan no matter when the last one was. On the other hand, though, if you're really stable and things are going well, maybe you don't need to do a scan if everything's been really rock solid stable for several years. Last 2 questions that I'm going to ask is, years down the road after diagnosis, can the antibody profile change? And the answer is that it can change. People do evolve over time. Sometimes people who have only an ANA or an anti-nuclear antibody as their only possible antibody may develop this topoisomerase or anti-SCL70 antibody later. On the other hand, some of the antibodies don't change. So if you were more of a anti-centromere antibody type of person, that's more the limited scleroderma, you're unlikely to develop the SCL70 or topoisomerase, which is more the diffuse scleroderma. Those ones you kind of go down a path and you stay there. But everybody's different. And if your symptoms are changing, it may be reasonable to check your antibody profiles again. But I don't think we need to be checking antibodies on a regular basis once we've made a diagnosis. The last question that I'm going to answer today is a question about stem cell transplants. So we mentioned a little bit about transplant on my treatment algorithm. I was very specific not to talk about whether or not it's bone marrow transplant or lung transplant. Both of those are viable options for different people at different times. And I don't have the time to get into the details of when we would consider one over the other. But I will say that taking these drugs does not exempt patients from getting a stem cell transplant or a lung transplant. Most patients would be on those drugs when they go for a transplant of whatever organ they're getting. The hope is that after a stem cell transplant, you can stop those drugs. And in some studies, for example, the Scott SCOT study, where they compared cyclophosphamide comparing to transplant, what they found was that people who got transplanted, most of them did not require drugs like cyclophosphamide or myophenolate a year after their stem cell transplant. But over time, the disease can come back, and then they may need to go back on those drugs. So those were some really excellent and interesting questions, and I hope that I was able to give answers that were clear to everybody. It's been an absolute pleasure to chat with you all today, and I really appreciate the invitation to come and talk to you. And I will send out, as I said, I'm happy to send out my slides, but I'm going to remove all of the copyrighted materials. But hopefully that still leaves you with some of the take-home messages that I described. And I'll have the references on those slides so you can use them at your leisure and you can look up those papers. It's a real pleasure to everyone. Thank you again, and I look forward to getting invited back to maybe talk to you again next year as we get even more treatments and more studies to talk about. Thank you, everybody.
Thank you so much, Dr. Shapera. It was such a pleasure to have you with us this afternoon. Again, some incredibly valuable information to our all of our members. So we thank you so much for your time and for taking the time to answer all those questions. It's so nice to have that interaction. So we appreciate that very much.
I'm sorry about the technical problems, but I'm glad we were able to get it all working by the end.
Please don't apologize. Thank you so much.
Great. Have a good day, guys, and enjoy the rest of the conference. And thank you so much for putting this on. I know the patients are just so lucky to have you guys pulling all these experts together to chat. So thank you for the invitation, and congratulations on a great conference.
Thank you so much.